Hi, good afternoon, everyone. So, everybody has a lunch. Refreshing is the question. कि खाने के बाद कौन refresh रहता है? Everybody feels more sleepy. But anyway, I am going to talk about a topic which is pain for any fertility specialist. Reason being, nobody wants to face. We are very happy getting patients who are like conceived, they have come to us for IVF, that's fine with us, but not with multiple failures because that's where the journey becomes very painful, difficult, teary, sad, all those things, isn't it? So basically, yes, we have a new baby around the corner, and as fertility specialists, we all love to explore new avenues, see where we can do certain things in a different way. So basically, this is my journey, which has been so far a small journey in comparison to a lot of other people. Though I completed my education way back in 2000. It was 2016 and only when I started my journey into IVF. That was a few years after having an international stint, staying abroad and other things. So from here, we move on to doing certain research work, papers, publications, some are for visual glimpses, and a book which I have written on social freezing, and this happens to be the first book on this very important topic, a more futuristic topic which is there. So basically now we come to the emotional weight of RIF. We all know it is very, very difficult, isn't it? The patient comes, asks us, why doctor did it fail? What answers do we have? And it is a journey of loneliness, of sadness, of cries, of emotional strain, familial and strain between partners as well. So as doctors, we also open all our arms to see what we can do differently, because strength doesn't come from what you can do, it comes from overthinking the things which you thought you couldn't. So with this, I begin my presentation, and this is, of course, the presentation roadmap, which I will be covering with this thing. And beyond the clinical challenge, I'll also be discussing about the immune paradox which is there in this condition and what are the things we can think about doing further. So basically, the clinical challenge, as we know, our definitions are also divided. The British Fertility Society says 3 or more failures includes an RIF, whereas ESHRIS says that it is an RIF only if the embryos had enough potential to give her a pregnancy. So by that, the incidence is around 10 to 15%, and of course, 1 to 2% of the entire reproductive age group women might suffer from it. We know the potential causes. Of course, RIF rarely has a single cause. It is a multifactorial condition, an interplay of the embryonic, uterine, immunological, and endocrine and lifestyle factors. We know psychological stress, nutritional, lifestyle, smoking, alcohol, all this has a play. Male factor is important. Uterine conditions are important. The dysbiosis of the endometrium, the endometritis, all these things have a role to play. The hypercoagulable states have got to play. Immunological, we are talking more and more about it because immunological causes are very, very important now. And of course, there is also the endocrine dysregulation, conditions like thyroid, insulin resistance, to name a few. And not the least is the genetic abnormalities. So what are the therapeutic options? As I said, the lady, we can't say RIF if you have done multiple failures in a lady who is more than 40 years because her maybe potential is not that good. And of course, embryo transfers of more than 3 or frozen cycles of blasts, which should be more than BB, and if D8 embryos, then the fragmentation should be less than 10%. Important is the genetic analysis, that is the chromosomal analysis. Beyond that, hysteroscopy is important. Endometrial biopsy is important to rule out endometritis. Immunology is important, the antiphospholipid antibodies and the anti-nuclear antibodies can be done, the endocrinology and the male factor. The DNA fragmentation can be evaluated in such cases, and accordingly the targeted therapy has to be planned. So what is the diagnostic workup? When we talk about the general diagnostic workup, we all know about, and beyond that, what comes is basically what we are talking is defining her potential to give the pregnancy. So what does ESHRE says is that you should estimate the chances of implantation. And if the chances of implantation of the embryo is more than 60%, then only if she fails more than 2 times can we consider her as a case of RIF. So it is very important to understand the implantation potential of the embryo before labeling her as a case of RIF. And if, of course, you have started her in ART treatment and she has had more than 2 failures, and her potential of the pregnancy, giving a pregnancy was more than 60%, then if she fails, then she needs an evaluation in cases of RIF. And if the potential was less than 60%, then the definition changes. So basically, what are the recommendations? Well, the recommendation is very simple. They say just make lifestyle changes, then reassessment of the endometrial thickness, and assessment of APA and APS. That's all what the ESHRE says. You can do it at the first line of treatment. Karyotyping of both partners, 3D ultrasound, endometrial function testing, endometritis, assessment of thyroid and progesterone levels, late luteal can be done. But something which are not recommended, sadly, currently still are vitamin D testing, microbiome, peripheral NK cell, uterine NK cell, T lymphocytes, assessment of blood cytokines, and lot of parameters. They are said to be still experimental, but of course, we as doctors at times are answerable, so there are a lot of things which we have to discuss and then take into consideration what actually needs to be done. So basically, we understand the immunological paradox because it's a baby which is there, and it is a semi-allogenic fetus. It will generate antibodies. The mother will generate antibodies against the baby, so that is to be there. The mother has to be protected from pathogens. The shift is from Th1 to Th2 helper cells we are aware of. So basically, the whole interplay is around the T helper cells and the T regulatory cells. We need more T regulatory cells to continue and Th2 cells to be there for the pregnancy to continue. And when the reverse happens, then we end up with RIF. So there is a disruption of this immune balance which can lead to implantation failure. So as we know that the immune system is very, very important, the most important 70% being the T cells, 20% the macrophages, and 10% the NK cells. So these are when they are depletion of immune cells at the maternal fetal interface is the one which leads to RIF, and that's where we are struggling if we have a patient with RIF. Now, RIF, as I said, rarely is a single cause. So other environmental factors and other things are very, very important. But when it comes to the immune evaluation, we need to understand that uterine natural cells are not cytotoxic at the peripheral cells. Okay, so it is the uterine level of NK cells which are important, because in RIF, the number of, there is dysregulation of the uterine NK cell and increased peripheral NK cells. And it is not only the increase in number, but also decrease in function. Then there is a T cell imbalance, that is, there is T2 helper cells decrease and Th1 cells increase because they are pro-inflammatory, and result is an immune tolerance. Besides that, the dendritic cells, the macrophages, all those are increased. This becomes very technical at these levels because we are not using these tests in routine testing, but now more and more labs are coming up and people are working on immunology and thinking what we can do in the testing, what can be started. So there is a lot of things which can be studied, and that is where we need to go beyond our comfort zone and see what we can do further. Of course, I've spoken about the peripheral NK cells and the uterine NK cells already. So they are central to the implantation and the continuation of the pregnancy. balance over the time is that implantation and early pregnancy is pro-inflammatory. Actually, pregnancy is very interesting because it has an initial pro-inflammatory stage where it lets the embryo to be implanted, and then there is a mid-pregnancy where it is anti-inflammatory, and then again it goes into the pro-inflammatory stage, and that is where parturition happens and the baby is born. Any disbalance over time leads to a pregnancy loss if we talk about it. Immunological factors, of course, is the cytokine imbalance, expansion of peripheral natural killer cells, dysregulation of the uterine natural killer cells, and allorecognition and untreated hypothyroidism. So thyroid is also very important. But as we know, just like one size doesn't fit all, so similarly is not one treatment will be leading to a success rate in all cases of RIF. So because there is a bidirectional interface between the fetus and the endometrium, there is apposition, adhesion, and invasion, and vascular remodeling happening at the same time, and that is where importance of these things. So what happens, there might be a disruptive endometrial receptivity, which needs to be corrected, altered expression of genes, immunological disturbances, epigenetic alteration, and as I've been telling again and again, an altered Th1, Th2 ratio, and NK cells. So if there is a TREG, the tree regulatory cells are depleted, again that can lead to the immunological disturbances leading to a RIF, the recurrent pregnancy loss. So basically when we are talking of RIF, the entire thing is around the immune dysregulation, which we need to understand. So it is whenever there is an immune dysregulation, will there be an embryo implantation which will fail. And there is a cytokine storm. So very clearly in these cases, the Th1 will increase, the Th16 would increase, the Th2 would decrease, and the T regulatory cells will decrease, and the uterine NK cells will not be working properly. So that's where the entire story is. We have been doing treatment options. Everybody has been using, some use lipids, some does LIT, others have used heparin, aspirin, steroids, HCQS, IVIGs, TNF-alpha blockers like tacrolimus. So everybody has been using something or the other in hope of giving an adequate result in cases of RIF. And now we have there's another LIT, a lot of people have used with limited evidence. I personally have not been a great in favor of LIT therapy generally, haven't found it very useful, but yes, there are people who have used. Now, with their associated side effects, risks as well. So now current therapies which have been used, nothing has been proven to be absolutely recommended or useful, and another baby we have around the corner, which is Thymosin Alpha. So now what to do, believe, not believe, give, not big, is another big story which we need to do, but we need to understand what Thymosin Alpha actually is. It is, of course, a synthetic peptidomimetic 28 amino acids secreted by the thymus, and basically it is a modulator of the innate immunity. Till now, the drugs act on one factor or the other, and this is basically a modulator. So this is a video. I thought I will use it in the initial part to play. How do I get to play? Can you play it from there? Please play it. So it's a short animation which sort of introduces the drug as to what it is regulating. It is a 2-minute video which will play. Yes. Where is the audio to it?
The greatest joy in life is becoming a mother. And IVF treatment is a dependable path to achieve this joy. The greatest joy in life is becoming a mother. And IVF treatment is a dependable path to achieve this joyful possibility. Yet, more than 50% women undergoing IVF treatment fail to become pregnant after the first embryo transfer. There are multiple risk factors which may lead to recurrent implantation failure or RIF.
Sorry for the glitch.
A balanced maternal immune system The greatest joy in life is becoming a mother. A controlled
Otherwise, I can continue. So basically, when we talk about thymosin alpha, it's a new drug and people have been using variably. The thing is that it is an immunomodulator. That is the biggest point of it. It is not that it brings down one totally. It helps in bringing the levels of TNF-alpha down, improving the levels of Th2 helper cells. That is, I can have my presentation then. So basically, these are the immunological changes which are the effect of thymosin alpha. You can look at that video and maybe we can play it in the end. So basically, the immunological changes are that there is increased CD3 count, decreased CD16, increase in Th1, decrease in Treg, and Th17 levels are increased. So basically, thymosin alpha has been seen to have a positive impact to reduce RIF on each of the factors individually. What is its mechanism of action is basically by immune modulation, number one. Then improving the Th1, Th2 balance, and also interestingly, it improves the endometrial receptivity. It may improve the implantation niche, it enhances immune tolerance, and has got no relation with age, BMI, and progesterone. The only limitation with the drug has been that the studies so far have been limited, so that is why this still comes under as an experimental group, and the studies which have been done, they did not have any control, so that is why individual small studies have been done. The importance is that the immune markers, they are modulated by the drug. The TNF-alpha, so what are the reference ranges is basically TNF-alpha, CD3 cells, the CD16 and IL-6. I'm sure everybody is not doing lot of these investigations because doing these investigations also comes at a particular cost, but we know that this is something which we can offer to the patients in patients of RIF, because when they want a pregnancy, most of them are ready and understand that they are ready for an evaluation, and this is what we have been doing at our center and our patients, because we have a lot of patients who come with multiple failures, 4 failures, 5 failures, and that is where we need to go and discuss with the patient, because if we talk only about guidelines, definitely the recommendation is not there very clearly, but if you have such cases, then that is where the discussion comes, that is where the entire counseling comes, and what is the will of the patient, that is very important. So basically, what has been found is on all these parameters, when thymosin was given, their values returned to baseline and reached within the normal range. So basically, the goal of thymosin alpha therapy has been to normalize the dysregulated immune modulators. So basically, what we are trying to do is just trying to modulate the immune system and not increase or decrease it. So this was a small subset of patients in which thymosin alpha we had given. Here the patients, there are 39 patients in which we have done an embryo transfers. The inclusion criteria was patients had more than 2 IVF failures and they agreed to undergo thymosin alpha therapy after proper counseling. And also the TNF alpha levels were increased in these patients. A lot of people will ask me that why the Th1, Th2 cells measure was not done in these patients. The mainly reason was the cost around it, and because once the patient already has spent from the pocket for 2 cycles or 3 cycles or more than that, then sometimes they are not very keen to get the investigations done before that. So with proper counseling and the consents, we did this thing, and we found that 48% of the patients who had had at least 2 failures, most of them were 3 failures or more than above, did conceive the pregnancy. This data has not been segregated on the basis of endometriosis, adenomyosis, or other things, because we still are working on these and studying further. So, but the preliminary response is very, very useful, and I would say reassuring, because somebody who has had multiple failures, if we are nearly achieving a pregnancy rate of 50% in them, it is something which can be offered to the patient. Of course, with coming times, I think we'll have more clarity about how much dose, what to give, how to give, what are the investigations required. Should we do all the immune profile of the patients? And I'm sure the labs are coming up which will be offered, will be able to give us things when we can offer to the patient at a better price. Now comes the clinical safety, because that is something which always worries all of us. So it has been available. This drug is not a new drug. It has been available till 1979. It is approved by US FDA, DGCI in 35 countries, used in 230,000 patients, and a lot of articles are around the drug. Interestingly, this drug was introduced in COVID patients, basically, to control the cytokine storm, and that is from where the use of this drug came in patients of RIF. And there is a very, very low incidence of adverse effects. These are other articles which show that it has been useful in preventing recurrent miscarriage and implantation failures. So these are the few studies. Basically, there was another study which was done, and they concluded that thymosin alpha may enhance uterine environment and improve the receptivity of the patient. So basically, how does it work is we have to identify the RIF patients with 3 or more failed cycles, in whom the primary thing is that we should always remember the transfer of good embryos were done. There's no point in transferring poor quality embryos and then saying she is a RIF. Evaluate the immune profile. Ideally, there should be a Th1, Th2 ratio, uterine NK profile if available, and clinical history. Then consider Th1 alpha. Of course, as I said, it is still an experimental therapy, and then monitor the outcomes in terms of HCG positivity, cardiac activity, and correlate with immune markers. So basically, what is the recommended routine right now is day 1, you start with 2 injections subcutaneously, 1.6 milligrams, so you give a 3.2, and then you give an alternate days till the day till 1 day before embryo transfer. And then the final embryo transfer is done. Lot of people are also continuing it further on a bi-weekly doses till the results of beta HCG comes, and when beta HCG comes, they continue it till first 12 weeks of pregnancy as well. So basically, if we have to see, then the benefit must be weighed against the maternal and fetal side effects. Since the side effects are few, we can give a try. Uses of lowest effective dose, and regularly evaluate if you are giving this treatment, what is the outcome of this. But to conclude, I would still say that ESHRE stance is very clear. The recommendation is still not for these immunological treatments or neither they say investigate nor treat them. So that is something which we have to be careful about. So whenever we are giving, there should always be a word of caution. A proper counseling, discussion, and consent remains very, very important for it. So basically, this was around thymosin alpha. I'd like to check if you have the presentation, if we can see the video. This is some of our upcoming workshops, because I see a lot of young people here. They can register for that. And this is the video. I'm sure it will not play. So basically, in summary, it is that thymosin restores immune balance, builds maternal tolerance, improves endometrial receptivity, and as an adjuvant to immunological factor in RIF. Or whenever we are dealing with RIF, one thing which needs to be kept in mind very, very clearly is that it is a multifactorial condition. It is associated with lifestyle changes, which are very, very important, besides other male-female factors and endometrial factors as well. So it offers more than an immune balance for couples facing repeated loss. It renews hope, and it's a chance for body to welcome the baby and hold a new life. So that is about it. Thank you. I'd like the video to be played again. Yeah.
The greatest joy in life is becoming a mother. And IVF treatment is a dependable path to achieve this joyful possibility. Yet, more than 50% women undergoing IVF treatment fail to become pregnant after the first embryo transfer. There are multiple risk factors which may lead to recurrent implantation failure, or RIF. A balanced maternal immune system plays a crucial role in the establishment, maintenance, and completion of a healthy pregnancy. Subsets of T helper cells such as Th1, Th2, Th17, along with T regulatory cells, play a distinct role during pregnancy. Under normal conditions, a controlled inflammatory response of the TNF-alpha produced by Th1 cells benefits trophoblast implantation. At the same time, cytokines produced by Th2 cells exert a dominant anti-inflammatory effect, thereby balancing the Th1 response and protecting the fetal development. The Th17 cells induce protective immunity against extracellular microbes during pregnancy. Simultaneously, the Treg cells regulate the local inflammatory immune responses, potentially detrimental to the fetus. However, in aberrant conditions, elevated levels of Th1 cells in the peripheral blood results in increased production of pro-inflammatory cytokine, TNF-alpha, creating an imbalance in Th1, Th2 immune response, which may result in implantation failure. An increased proportion of Th17 cells and related cytokines and depleted levels of Treg cells and its cytokines in the peripheral blood may result in RIF. Hence, a balance between Th17 and Treg cell immunity may also determine the pregnancy outcome. Studies suggest that Thymosin Alpha 1, a peptide secreted by the thymus glands, plays a vital role in regulating the desired concentrations of Th1, Th2, Th17, and Treg cells in the peripheral blood, which may eventually result in a successful pregnancy outcome. However, depleted levels of thymosin alpha in maternal serum may lead to immune disturbances in periconceptional endocrine, leading to RIF. To improve the implantation rate and clinical outcome in RIF patients,
Fertimax, a division of Gufic Biosciences, brings to you
Thymosin Alpha injection modulates immunity
effectively.
Thymosin Alpha 1 in Thymosin Alpha is a synthetic peptidomimetic hormone of thymosin containing 28 amino acids. Thymosin Alpha is a safe, well-tried, time-tested, and widely approved by regulatory bodies like US FDA, DCGI, and recognized in 35 different countries. Thymosin Alpha 1 in Gunjan Alpha reduces Th1 cells and elevates Th2 cytokines to a balanced ratio, reduces the secretion of Th17, and increases the levels of Treg cells, leading to improved pregnancy outcomes. Adhering to this dosage protocol of Gunjan Alpha during pre-ET phase may improve implantation rates in RIF patients. Doctor, spread the joy of motherhood with Gunjan Alpha. Modulates immunity effectively.
Let's have a big round of applause for Dr. Gunjan Gupta Govil. Thank you so much, ma'am, for that insightful presentation. Ma'am, we request you, Gunjan ma'am, we request you to kindly please stay back, and I would like to invite Ms. Khushbu Sharma. Ma'am, please come on stage and felicitate Dr. Gunjan Gupta for this amazing presentation we have. And let's give it a round of applause for Dr. Gunjan Gupta.